Perhaps we can invite the speakers
Yes, yeah.
Andreas?
Do you mind, Andreas and Corrado to sit on the stage? So, Andreas,
my question for the first speaker, my name is Shiraz Ahmed. I'm a breast surgeon from Qatar. So with all the presented data and data available in the literature, still many physicians, they believe that neoadjuvant systemic therapy is an option only for postmenopausal women. While those young patients, young with a good performance status, they still offer them chemotherapy. So my question for the first speaker, with the non-availability for the Oncotype DX and the other genomic assays, still you offer chemotherapy for young women with good performance status?
Do you mean in the neoadjuvant setting?
Yes, with the luminal A.
Yeah. Okay. Actually, the use of genomic signatures to decide the neoadjuvant treatment is not the standard yet, but of course we may use it. In US, they use that more often than we do in Europe. Of course, it's something that may help us because we know that just one of these genomic classifiers, I mean, the Oncotype DX has a predictive value as well, and not only a prognostic value. So I think that we have some tools that can help us identify those patients that may be candidate to neoadjuvant endocrine treatment rather than chemotherapy, regardless the menopausal status. So I think that the biology matters more than the age of the patient, and we don't know about true differences in treatment effects based on menopausal status because we can render premenopausal patients postmenopausal with ovarian function suppression. So I think that the neoadjuvant endocrine treatment is an option also for premenopausal patients, but of course this has to be balanced, taking into account different biological and clinical pathological characteristics.
Thank you.
Okay, thank you. Any more questions from the audience? Feel free.
Good morning. This is Emanuele Garreffa from the UK. I've got a question to all the speakers, which is what's the approach in your unit for calcifications after neoadjuvant chemotherapy, both residual and new? And then a second one, just for Dr. Tinter, is why you did not include women under 40 in your trial?
Please.
Yes, the question is historical. Because all the Veronese study, yes, I know is not so, I think is not so clear, but all the previous Veronese study, Milan 1, Milan 2, and Milan 3, comprehend the patient from 40 to 75 years. So this is the only model that we use in this classification. But I think that this data is also important for the women younger than this. About the first, I think that the tumor burden after neoadjuvant, I don't remember the first question.
If you have calcifications after neoadjuvant chemotherapy, either residual or new, so what's your approach? You rebiopsy, you take the whole tumor footprint, you just take a representative sample during the first surgery? What's the approach in your unit?
So this is a very, very nice question. The honest answer is that I am fighting with the radiologist about that. However, one has to be pragmatic. If I see that the extent of microcalcifications is expected to affect what we can offer for surgery to the patient, then I will ask them to biopsy the perimeter. There are, however, cases where the extent is so large that you can never, from a pragmatic point of view, get adequate sampling that will exclude the possibility of underlying persistent DCIS. And this is something that is taken with the patient. Unfortunately, there have been cases that we had a breast that was, taken by invasive tumor and calcifications, and we had only the microcalcifications afterwards. But this is a case where I don't know of any diagnostic modality, and the VAB is not there yet, at least, to tell you that you can piecemeal excise half the breast in order to reduce surgery, because you have actually performed surgery through the VAB in this sense. This is discussed with the patient, but if we feel that we need to know things that can affect the extent of surgery, then we ask them to do the biopsy again and to clip again, depending on how we have clipped and marked from the very beginning.
Yes, we define the bioprofile with the true cut, and not only with the surgical biopsy. I think it's very important to define the bioprofile also in the axilla. So the date of the axilla, I think, is very important when you start the neoadjuvant treatment. I think that it was a question, yes. Thank you.
Okay, thank you. Perhaps we have time for one more question?
If we have time for one more question, can I ask the question?
Yeah, of course you can.
Okay, thank you very much. So this is a question to Carmen, because the neoadjuvant endocrine therapy, I think, is a future that we are not taking advantage of. A very relevant question for us surgeons is the following. We have yet to establish the optimal duration of neoadjuvant endocrine therapy in order to succeed in converting or downsizing in order to downsize to surgery enough. Is there any data suggesting of a smart way to define the expected tumor response early in the course, meaning that it is a little bit pointless from a practical point of view to administer neoadjuvant endocrine therapy for 4 months without knowing if the patient is going to respond. And we know that the radiologic response is a little bit tricky because you also most of the times you have a swelling because of tumor recrosis and response. So the first ultrasound will probably show that the lesion is a little bit larger than it was before the induction and so on. Do you have any data on that?
Yeah, actually, that's a very good point because I think that one of the reasons neoadjuvant endocrine treatment failure in the past years has been the wrong duration of such treatment. Because as I mentioned, the first trials investigated a 3-4 month duration with endocrine treatment based on trials with chemotherapy, but these drugs work differently. So we know now that if we want to use neoadjuvant endocrine treatment, we should keep treating the patient for at least 9-12 months. PCR as an endpoint is not that accurate in luminal disease as in triple negative and HER2 positive disease. However, regarding your question about early benefit detection, we have some biological tools that we may use, such as the PEPI score or the Ki-67. We have seen a correlation with the Ki-67 drop at 14 days and correlation with the final outcome. So in this, of course, will require one more biopsy, and it's not always feasible, but if it's possible, it's something that may guide our decision about the treatment with neoadjuvant endocrine treatment. Of course, this is something that requires a bit more patience than chemotherapy, but not all luminal cancers are chemosensitive, chemoresponsive just because of the tumor size. So maybe sometimes these tumors may be more responsive to endocrine treatment. And last but not least, please consider that now with the advent of CDK4/6 inhibitors that may be already used in combination with endocrine treatment in locally advanced, in early stage locally advanced breast cancer, we may have also improved and faster response rates.
Thank you very much. The reason that I'm just putting the question is I'm sure that I'm not the only surgeon in the room thinking about it. It would be a very attractive alternative to know that if you can rebiopsy on 2 to 4 weeks, for example, then you may have definitive information of whether it is meaningful to continue in order to downsize the tumor, or you can inform the patient that it's going to take longer. That was the point. Thank you very much.
Yeah, and that's a very important point because surgeons and oncologists need to be aware of these early biomarkers evaluation.
And surgeons are more impatient than patients.
All right, thank you. So perhaps we have time for one more question from the participants. For Andreas, for you. In your experience, how do you manage with surgery after complete response after neoadjuvant treatment? Do you remove all the tumor bed, or just the clip and a small part of the tumor bed?
So the standard approach for us is to perform standard clipsectomy. We will not remove the entire tumor bed if we have the type of tumor that we know responds. Sometimes you know, and this is why it is very important to account for the biology of the tumor from the very beginning, that if you have an unfavorable biology, for example, a lobular cancer, it is very probable that you will have a scatter pattern response or in the luminal B setting, for example. And this is something that one can take into consideration. However, the rule of thumb is that if we have radiologic response, then we perform risk-adapted surgery. So we do not remove the tumor print.
All right, thank you very much. I guess we should move on now. Let's proceed with the keynote lecture. Thank you very much.
Thank you.
So